Hi, my name's Sam Ord. I'm an adult ICU specialist at Nepean Hospital. We're going to try and do a demonstration here about how to do a focused paediatric scan. As I said, I'm not a paediatric intensivist, I'm an adult intensivist. So I'm going to try and use some of these tips and tricks that I've learned from doing adult scanning to try and scan my son Jack. Thank you very, very much for being part of this, Jack. He's been very, very patient with me, and I'm having to bribe him fairly heavily, and very welcome for comments and ideas about what suitable bribery would be for this. And again, just thanks, buddy. I'm going to try and show you how to take these images, right? And that's just one part of having to do a focused scan in a patient. Let's remember, first of all, why we're doing these. We're often trying to do this to differentiate causes of shock. And that means that we are trying to determine, is there a cardiogenic component to the shock? As in, is the LV abnormal, yes or no? We're going to need to try and have a look if the RV is abnormal from pulmonary hypertension or a PE, or for example. Is there any signs of significant hypovolemia? Is there any sign of significant tamponade? There's a pattern recognition. I think the vast majority about 2D echo is about subjective analysis. So it's trying to recognize those patterns of what LV dysfunction, RV dysfunction, hypovolemia or tamponade look like is what we're trying to determine with echo. It should only take about 5-10 minutes. It should be adequately quick enough that you can integrate it into your clinical management of a patient. And it normally takes about 15 to 20 studies for you to be able to figure out how to do that. What we're going to show in this video is how to take those images. But once you've taken that, you've got to be able to interpret those images. And you don't make assessments based on one view alone. You use as many views as you can. Once you've made that assessment, you're then going to have to integrate that assessment into the clinical management of that patient. And each one of those stages takes a little bit more time to learn. So we'll go through a few tips and tricks on how to do the scan. Okay, first of all, about how you hold the probe. So I hold the probe like a pencil so that I can rest my hand on the patient's chest after that. For your parasternal long axis view, you're going to be wanting to sit in approximately the third intercostal space, so just down below from the Ziphy sternum, with the marker of the echo probe pointing towards the right shoulder of the patient. So, and the angle that you're trying to assess is in what's known as, we're looking for the parasternal long axis, which means that we're looking down the long axis of the heart. So if the apex is down here, we're angling sort of in that diagonal line across the heart, trying to look into your parasternal, looking into that parasternal space. Now the movements that we're going to look for are going to be down and up. We can go left and right and left. Or you can keep that foot plate in the same position and you can fan. And that means that you can see how the image plane changes as we fan up and down. And that's different from the next movement, which is known as rocking or heel to toe or fishtailing. And this one is where the image stays the same. Like if you have a look here at the aortic valve, for example, if the aortic valve is on the right side of the image, if I do that heel to toe or the fishtailing, I can move it over onto the left side of the image. The image plane stays the same, but the orientation changes. The next movement is rotation. I try and use my left hand to hold the same position, and then I rotate with my right hand. And whatever's in the middle of your screen on one plane, like here's the aortic valve again in my parasternal long axis view, as I rotate round, it stays in the middle of my view on the next image. Try and show that maybe a little bit better. So here, if you've got the aortic valve in the middle of my screen in one view, if I rotate round, the aortic valve's in the middle of my view on the next view. The last movement's not in the textbooks. I call it snuggling. And basically what that is just trying to talk about nestling into that intercostal space. If I'm pressing too lightly or I'm over a rib, you sometimes can get it's almost like a hazy appearance to the image. If I can provide just a little bit of pressure and just gently rock off a rib, can you see that the image just looks a little brighter and a little crisper? And that's just nestling into that intercostal space, improving the contact, helping those sound waves come from the echo probe into the patient. Okay? With that parasternal long axis view, I'll just try and go through each of these views, talking about the orientation that we're after. So first of all, let's just show you this. So what we're trying to aim for is a picture that looks something like this. Okay? Where we've got our aortic valve, right ventricle, left ventricle, mitral valve, and left atrium. So the view that we're after is something that looks a little bit like this. Aortic valve, right ventricle, left atrium, with the mitral valve in the middle there. Bright line is the pericardial space. There's the lung behind it if we change our depth. I'm going to use almost this aortic valve as the fulcrum for this view. I'll often bring it into the middle of my image first of all. Try and do little bits of movement, trying to brighten up that image, just pressing, nestling in that intercostal space. Bring it to the middle of my screen. I'll do gentle bits of fanning, trying to look to try and find the axis of that left ventricle. If I go down too low, that's looking at the right ventricle. If I always go too high, I can always look at that pulmonary valve. And I'm just going to try and make that left ventricle look as big as possible. I'm still not perfect. Just going to nestle into that intercostal space. And this is where you can see the left ventricle, like almost like, am I seeing the apex coming in here? But the left ventricle is not like 3 centimeters long. And if you can look at the orientation that I'm holding the probe, I've got to rotate it round. And as I rotate that probe round, if I go too far, it goes and cuts off again. If I go the other way, it opens up. And I'm just going to do little bits of rotation, trying to open up that left ventricle as much as I can. All right? I'm going to want to do little bits of fanning, little bits of heel to toe, just so what I'm interested in fills the screen, and I've got that left ventricle opening up into that ascending aorta. And that's when I press store, and that's when I make my assessment. Have I got signs of LV dysfunction, RV dysfunction, horrible hypovolemia, signs of tamponade? And then I'm going to move on. You don't have to have amazing pictures to get that done, but obviously it helps. Okay? Okay, so next view. Put that aortic valve into the middle of my screen, and I rotate my probe around. So the aortic valve stays in the middle of my screen at the top. I'm going to do just little bits of almost tiny little circular movements, just trying to nestle into that intercostal space. And here I can start to make my assessment. There's my aortic valve, left atrium, right atrium. That interatrial septum in the middle, trying to determine if it's bowed one way or the other, showing signs of significant raised pressures. There's the tricuspid valve, and there's the pulmonary valve with the right ventricle in between. I can start fanning down through the structure, and there's the mitral valve. See if I can just get a little better on axis. There we go. Just came up a rib space. I'm just tucking myself in next to that parasternal space, trying to make the ventricle look as circular as possible, trying to make sure that I'm not off axis. Jack, do you mind just rolling over towards me a little bit? That's it. Perfect. Great job, buddy. So there's our aortic valve, left atrium, right atrium. As I fan down, there's the mitral valve, anterior and posterior mitral valve leaflet. Here's the left ventricle, there's the right ventricle. Fan down to the mid-ventricle level with the anterolateral and posteromedial papillary muscles, and down to the apex, and I lose those papillary muscles, and you can look at the apex. And this is often my go-to view for trying to determine if there are the abnormalities I saw in other planes were present on this one, because it's often this is the hardest view to sort of mess up. So I start off at that apex, so I start off at that aortic valve level and just fan down through the heart all the way from the top to the bottom. Okay, next view we're going to go for is the apical view. Apex, holding that probe like a pen, have that marker pointing down towards the bed, feel for the apex beat, and I point up towards the patient's right shoulder. And I'll just try and find something that's moving around. And here underneath this, I can almost see this is the right ventricle here, this is the left ventricle, left atrium, right atrium. So that tells me that I'm sitting too medial. And it's really common for us to find that in the apical views we sit too medial, and in our parasternal views we sit too far lateral. So I might just quickly just show that if I can. So in your parasternal views, if you start to see these dirty shadows like this come in, that's lung. We'll talk about that in a moment. But you want to try and push yourself over to what you're in, till the parasternal structures are more visible. You don't want to go too far as that gets bone where it all looks black. There's the heart. You come too lateral, you get the dirty shadows of the lung. So you're just going to try and find that sort of 20 cents piece that you want to nestle into. Apical views, marker down towards the patient. You don't want to sit too medial because you're sitting right over the right ventricle. I want that interventricle septum right down the middle of the screen. So I'm going to try and follow that rib space round until that interventricle septum is pointing towards the apex. I can then fishtail, and you see how that interventricle septum then points towards the true apex. And now I can turn up the depth. Did you see this structure here? That's a black line that comes across the screen. That is the coronary sinus entering into the right atrium. Now that tells me that we're pointing too far posteriorly. And so what I'm going to want to do is then fan up. If I go too far, you can see the aortic valve starts to come in. And that's going to tell me that I've got to angle back to get rid of that structure. Okay? So there's our apical 4-chamber view. Now, one of the things that we might be able to see with this is that the right ventricle actually looks a lot bigger than it did in some of the other views. And that whole heart looks almost spherical in shape, like a soccer ball. So that might tell us they're actually a rib space too high. And so what I might try and do is even come down a rib space and angle up. And here you can start to see it. The true apex is maybe a little harder to view, but it looks much more like a rugby ball. And you can see it almost looks a bit longer than it did before. And that right ventricle doesn't look as big as it does when I'm a rib space or two higher. Can I demonstrate that? You see how it's the heart looks spherical, right ventricle looks enormous, big as the left ventricle, and that's different than if I'm a couple of rib spaces lower and looking up. And again, maybe that highlights the importance of making, before you start saying the right ventricle is big in one view, you've got to look at it in multiple views. To try and do the 2-chamber, I bring the left ventricle into the middle of the screen, and then I rotate round. Try and avoid those, try and avoid the ribs. And this is the hardest view, particularly I think in kids it can be tricky. So I try and bring that left ventricle into the middle of the screen, rotate round. Try and do little bits of fanning, try and get from the true apex. Take a big deep breath in for me, buddy. And breathe out all the way. And hold it there. Yeah. So just trying to do little movements to try and get a 2-chamber view that looks like that. And then breathe away normally. Okay? A little tip and a trick. Okay, last view is the subcostal. I'm going to hold my probe in a slightly different way. I'm going to have the patient lying flat on their back. I'm going to put my hand over the probe like this so it's nice and flat, and I have the marker pointing towards the patient's left. I press down on the tummy underneath the rib cage at the Ziphy sternum. And I look down into the heart. I'm going to have to increase up some of the depth so that we can see what we're looking at. And I can see this structure in the middle that looks a bit weird. You know, here's the right atrium, here's the right ventricle, left ventricle, but I can't really see the left atrium and this kind of spherical structure in here that looks like it's a valve, and that's the aortic valve. If we remember, that sits at the front of the heart. So we've got to fan back. I've got to fan down till I get rid of that structure. If I look up again, there's the aortic valve, fan down, and now you can start seeing that left ventricle in a bit more clarity. I'll try to look at that left ventricle and I do little bits of rotation, one way or the other, trying to open up that left ventricle as much as we can. So if I over-rotate it, it gets smaller. If I go back the other way, it gets bigger. If I see that aortic valve, I fan backwards. Make sure I don't rotate too far, and go the other way. Left atrium, left ventricle, right atrium. To look for the IVC, I bring the border where the IVC might be coming in and I just fan upwards and downwards. So I start seeing that IVC entering that right atrium. I keep that in the middle of the screen and I rotate round until it looks long and thin and enters into the right atrium. Yeah? I do the same thing every single time. This is where you can make measurements either in the long axis, or if I rotate back, you can measure it in the short axis. But with the measurements you make, just make the same measurements every time. And I find that these measurements are probably the most useful for looking for estimations of right atrial pressure rather than fluid responsiveness. If we carry on fanning over now to the other side, we get an idea of finding the aorta. So that's this structure that's sitting in here. And that aorta's got a pulsation to it, so we get a slightly better view. Where is it? There's our IVC. Look over to the patient's left. There's the aorta. It doesn't enter into the right atrium, obviously. It doesn't have hepatic veins coming off it, so don't get it confused with the IVC. But if you carry on going and fanning over to that patient's left, you can get the lovely, nice final view, which is really good for patients who are on things like mechanical ventilation, because sometimes it's a bit hard to get some of the views. And here you can get what's known as a subcostal short axis. And here's the left ventricle with the right ventricle around it. And if I keep fanning one way, you go down to the apex, keep fanning the other way, the mitral valve all the way up to the aortic valve. Which you can't quite see brilliantly there. But you get the idea, right? So that you can have another bite at the cherry of trying to have a look at the heart. So in summary, you've got 3 places, there's 3 acoustic windows, parasternal, apical, and subcostal. And you've got 6 different types of scans that you can do. Your parasternal long, parasternal short, apical 4, apical 2, subcostal 4, subcostal short axis, and then the IVC as well. The last little bit I'll show you is lung ultrasound, okay? So lung ultrasound, I use the same probe. If you've got a preset for lung ultrasound, use that, because you're going to want to try and do artifact suppression. One of the things that we might be able to do on this echo machine would be to try to turn off harmonics and things like that, but if you've got a preset, much better. I hold the probe in the same way, but I have the marker pointing towards the patient's head. And I'm going to put the probe where I listen with a stethoscope. At the top of the right lung, top of the left lung, bottom of the right lung, bottom of the left lung, posteriorly of the right lung, posteriorly at the left lung. And I'm looking at 2 things, pleura and parenchyma. So for pleura, I reduce my depth to about 5 centimeters. And I try and find it where the whole thing goes black, that's a rib. As I slide down, I'll then come to another rib. There it is. So I'm just going to want to be somewhere in between that. And what I'm looking for is this twinkling line at the top between the 2 ribs. There's the inferior one, there's the anterior, upper one. And this speckling movement is what's called ants marching. It's the viscera and parietal pleura coming over each other. And that's a sign that you've got no pneumothorax. It's obviously going to happen in the most anterior portion for patients who have pneumothoraces. So you can slide down to get what's known as the lung point sign. Sometimes if you see a pneumothorax, trying to find where there is visceral and parietal pleura against each other, so normal pleural interface, as opposed to where the pneumothorax is. And you can look on the left, on the right, on the left as well as the right. One of the things I do is just little bits of fanning from one way to the other, just trying to optimize the artifact viewing. Okay. Next thing is to look for the parenchyma. So the parenchyma, we're going to need to increase up our depth to about 10 centimeters or so. And again, same places. Here's our go in the right upper zone. And I'm just going to move, try and optimize the TGCs. And just do little bits of fanning one way or another, just trying to maximize and snuggle into that intercostal space. So just little circular movements just to nestle into that intercostal space to maximize the views of the lung. And what I can see is normal lung A lines. So this is where there's just normal aeration of the lungs. So the sound waves get bounced around between the pleura and the skin, which makes these sort of very equally spaced out horizontal lines of decreasing echo intensity that come down towards the bottom, known as A lines, totally normal. And again, I'll look on the right side, I'll look on the left side, just nestle into a spot to maximize it. And here I can see those A lines coming down again. I'll look on the right base, come up a little bit, just nestling into there. Nestling in, and there are the A lines again, coming all the way down, and I'll look at it on the left side as well. Lung ultrasound are generally fine. When you're looking for the lung, you find the heart. When you're looking for the heart, you find the lung. That's just fairly common for all of us, unfortunately. See, there's a perfect two-chamber view that I couldn't find before. It's ideal. And just try and find a little spot where there's just lung. Okay. One of the things we can show you is if we look at the base, there's the liver. If I turn up the depth, and there's this bright white line of the diaphragm. If Jack, you take a deep breath, you can see now we get the lung shadows start coming in, and breathe out all the way. That's called a lung curtain sign. As he breathes out, the lung comes back in. We can see that on the other side with the spleen. Breathe out all the way. That's a good boy. So there's the spleen, there's a kidney. See if I can find the bright line of the diaphragm. So I'll just breathe away normally. So here's the spleen on the left side. There's a spleen, there's the diaphragm. And again, you take a deep breath in for me, buddy. And there's the dirty shadow of the lung that comes in, called the lung curtain sign. I hope that was useful. Just a demonstration of how to do a quick point of care ultrasound scan for the heart and the lungs. Thank you again to Jack for all your patience. You're an absolute champion, buddy. Yeah, thank you very much. I'm sorry I can't be there in person for the Adelaide course, but it's really great to be able to talk to you. Thank you very much.